Welcome to the Healthcare IT Today CIO podcast. I'm John Lynn, the founder and chief editor at Healthcare IT Today, and I'm excited to bring you the most practical healthcare CIO insights and perspectives. We know your job is challenging, and we want to help you be more successful. And today's guest is someone who I know can achieve that goal. I've known him for a long time, has a lot of great experience in healthcare, and his name is Rusty Yeager. He's Senior VP and CIO at Encompass Health. Welcome, Rusty.
Hey, John, looking forward to the conversation. Thanks for having us.
Yeah, I'm not sure why I didn't have you on sooner. I should have, I don't know, that's on me. Yeah, because they have such great insights. But those that don't know about you, tell us a little bit about yourself and Encompass Health.
Okay, I've been at Encompass Health for 21 years now. And I separated from the Air Force right at the 2000 tech boom, wanting to try, public health care. And so a friend of mine, many of you might know him, Randy Carpenter, asked me, well, come on over here to Birmingham, Alabama. And, I got a job for you as director of infrastructure. And I said, well, Randy, I'll come over there, but I'm just doing that for the interview practice. I don't really want to move over there. And when I moved over here, I fell in love with the mission. I fell in love with the community. And 21 years later, here we are. So and a little bit about Encompass Health. So we're a little different. We own and operate 151 inpatient rehabilitation hospitals. 55 of those are joint ventures with folks like maybe are out in the audience, acute care hospitals, academic medical centers, and 55 of those. So every year we discharge every year now, because we're growing so big, about 203,000 patient discharges a year.
Wow.
And about 4.2 billion in revenue. And we serve about 31% of the Medicare inpatient rehabilitations, patients across the United States. Recently, over the last 2 years, we got some great accolades from the community. We were Modern Healthcare Best Places to Work in 21 and Fortune's Most Admired Company in 22. So really some great stuff going on here. I got a great team. They keep me out of trouble. I was mentioning earlier, I don't do IT, I just talk about it. So let's talk about it.
Yeah, excellent. Well, I think it is a little bit different, right? I don't think we've had a CIO from rehabilitation hospitals. Maybe there's one or two in their portfolio, I guess. But what makes being the CIO of an inpatient rehabilitation hospital maybe different than some of the other acute care hospitals out there?
Yeah, it is different. And it's probably good to talk about what an inpatient rehab hospital does. A lot of people don't understand that.
Sure.
So we do PT, OT, speech for patients that need inpatient rehabilitation post their acute care stay. So typically these patients have a stroke, they've got a brain or spinal injury, dysfunction, neurological condition, and they need care post their acute care stay. So we actually get involved with those patients before they come to us. And what we do there is we evaluate their ability to do inpatient rehabilitation care, because they've got to be able to do it for 3 hours a day while they're in our hospital, according to the guidelines. And so we need to make sure that they're good for the program and are able to do that. So that's the first encounter we have from an IT perspective. So we have salespeople, clinical liaisons that go in and evaluate the patient. We capture that all electronically, and we pull that into a physician view, so the physician can actually evaluate and make sure the patient is eligible for inpatient rehabilitation care. So a lot even going on 2 or 3 days in advance before our admission. So we are less complex. We got a single sole focus, which is to get that patient back home to the goals that they want to have. So we are on that mission. We don't have EDs. We're not doing surgeries and the like, but we are 24/7, 365 like any other hospital. And we have doctors and nurses and pharmacists and the complement of that. We typically outsource lab and radiology services, but then they interface back into our system, and we have a full EMR, which we'll probably spend some time on. One of the things that we do, which is probably different from a lot of the acute care hospitals, is we're intensely centralized. So we have a single database for our EMR, and we have a single IT support organization for the company. And so the company has about 33,000 employees that are working with us, at any one time. Of course, it's 24/7, but typically about 12 to 13,000 people are working in our EMR in a single day. Wow. And we do that from Birmingham, Alabama. So if you've got a problem in our hospital, you call us 1-800-CALL-ITG, and we fix their problem from here to the extent we can. So we do everything with the exception of really physical hardware changes or modifications from here. And that is, our ability to scale that has been really a great benefit for the actual users of IT, as well for the economics of the organization. IT has gotten so specialized that a lot of times our hospital CEOs will ask us, well, I need an IT person. Well, the IT person that you get today can't do all the things in that hospital that you would like them to be able to do, because this thing is so scaled out that they wouldn't have the abilities to do that, because it's run here. And so sometimes we will allow that, but typically all of it is run out of here. And in fact, we have what we call IT liaisons out in those hospitals that are actually, they've got a full-time job, but they volunteer to kind of serve as the go-between sometimes. So some of them are therapists, some of them are controllers of our hospitals, things like that. So they're kind of our eyes and ears out in the hospital. So we do that with about 198 IT people and about 56 clinicians that are on our clinical EMR team.
Interesting.
I probably spend more time on technical challenges than the average acute care CIO would. One of the reasons is we can't buy anything off the shelf. We are the largest inpatient rehabilitation provider, and a lot of our other rehabilitation competitors, for lack of a better term, aren't scaled up to be able to do the things that we're doing from an IT perspective. So there's not a lot of business activity in inpatient rehabilitation. So when people come to us to try and sell us something, we have to make sure that we don't want to customize anything, but can we configure it to our particular workflows and requirements for inpatient rehabilitation?
Yeah, no, that's a really great point. And I want to dive into that centralization of IT in a second, but I just think about what you described. I think you said 50 partners, if I remember, that you work with. It feels like that referral and that interoperability of data matters a lot more to you than it does a lot of other organizations. It sounds like you've digitized that referral process. Is that how you approach it?
Yeah, we really had to. I mean, the ability to scale was challenging. It was faxing. It was, okay, you find the fax, get it to the physician, have them sign that, then scan it into the record. And when I first took over as a CIO, I was like, man, can't we just, digitize this? And it took us a little bit of time, but we were able to build an incredible, I call it the killer app, because, we've got it on an iPad, we got it on PC, and our clinical liaisons that are out in the field are taking a lot of data that then begins the care if the physician, is able to accept the patient. So all of that data starts before we even admit the patient. So from the interoperability perspective, I think we've all kind of been there with it. If you build it specifically for a workflow, then you get a lot of value out of it, right? If we're moving ADT around, it's kind of challenging to get that. And we'll get there over time, but it was a business and clinical necessity for us to build something specifically for these workflows.
Yeah, absolutely. Well, let's talk about your decision to roll out a standardized EHR across your whole organization. You've rolled out Oracle Cerner there. What was really the key to success, and maybe some of the outcomes of that decision to kind of standardize the EHR across all these different, clinical locations?
Yeah, it's a really neat story. So about 2009, the high-tech act was in the offing, and we started thinking 90% of our patients come from an acute care hospital. Mm-hmm. So they're going to have an expectation at some point that we're starting to do, interoperability. And this was, before interoperability was really in the headlines, but we knew that would be something well, the prescient leadership of the organization knew we needed to do some of that. I have been having done that in my past career in the Air Force, meaning rolling out EMRs. I was pretty scared. I was thinking, what? We're going to roll out an EMR to, this many hospitals. At that time, we had 98. So I had a little trepidation about that. But I also reflected it as something that we needed to do. So the organization, we did an RFP. We had several folks respond to the RFP. We tabled it for a little while, and then we got back to it, and there was 3 folks that were interested. Ultimately, we decided on Cerner because they had some experience in inpatient rehabilitation with what used to be called the Rehab Institute of Chicago. Okay. And that was interesting to us because, as I mentioned earlier, things aren't off the shelf for us. So we knew we were going to need to do a lot of customization, configuration to meet our particular requirements. So we went with Cerner, and we call it Advancing Clinical Excellence through IT, ACEIT. So that's been a really good rally point for the team. We're acing it. So we rolled out to a de novo hospital that we built in Northern Virginia in June of 2010, and it went pretty smooth. And then we rolled out to 2 more de novo hospitals. It went pretty smooth as well. Okay, we're feeling pretty sporty about it. But when you think about that, right? So this is a new hospital. A lot of our team members are new to inpatient rehabilitation. It was working pretty good. And so then about 18 months later, we went to our first existing hospital. We went out to a hospital in Phoenix, Arizona that had a really great CEO and began our implementation there. So there's when we hit some challenges, right? We've got a hospital that's been in existence for 20 something years, and they know inpatient rehabilitation better than a de novo hospital and my small team of clinicians know, and they've got workflows that have been in existence for years and all that kind of stuff that is very typical in the acute care side, but less typical for us at that particular time. So we began working with them, and I got a call one day, and it's like, Rusty, you need to come out there. And the CEO of that hospital was a friend of mine, and I said, okay, I'm out there. So when I got out there, we had some challenges, and we got together. I said, we've got to get together here. So I got the hospital clinical team and my clinical team together, and we came to an understanding that we're all in the boat together, and we're going to be listening, and we're going to build this thing for you guys. And so we did that, and it went over well. And then about 18 months later, or 2 years later, we decided to go enterprise wide. So over that time, we had 98 hospitals. We plan on a 5-year rollout because that was our ability to pay for the EMR as well as the change that it was happening to the whole organization, right? So as that went, we went on schedule, on time, and on budget, and it was working out well. So then we started thinking, man, we got this bolus of data that nobody else has. What can we do with that? And I sat in a meeting with one of our senior VPs, and he said, if we could just affect this acute care transfer ratio, that would be nice. And so it would be great for the patient. It's great for the company in terms of our outcomes. What do you think we can do? I'm thinking to myself, we've got all this data. Why don't we mine this data and see what the things are that people can't see, but the data can see? And so we approached Cerner about it. They were interested. They had the data scientists. We didn't have data scientists. We had the clinicians that know rehab very, very well. Let's put them together. And they ended up building an algorithm. We call it REACT, reducing acute care transfers. And acute care transfers is not a good thing for us. It's not a good thing for the patient, right? So when we went after that mission, we spent probably 18 months crafting this. And then we rolled it out, and we've been running it ever since. But it has had a great impact on those acute care transfers. And the beautiful thing is, with the number of patients that we discharge a year, if we can affect 1% of that, that's a lot of people. At the time
Yeah.
it was probably 1,500 people. Now it would be 2,000 people. So that was our first real great outcome from putting it in. These hospitals were completely paper with the exception of an older pharmacy system. And in 10 weeks, they went from paper to one morning they walked in and it was completely electronic. And then, let's call it a year or two later, they were getting in the workflow observations about a patient's condition that would have been hard for them to see, even in an EMR, much less a paper-based record.
Yeah.
So it was really about process, standardize the process, which Encompass Health had done really well at. And then let's automate that process. Then we can scale it. Once we scale it, then we can get data at scale, and then we can use our clinical and business knowledge to infect, process improvement. And the best thing about that has been, then we're able to build it into the workflow. So it becomes natural. This is just how we do it, like that old disco song. This is how we do it. And we do it that way everywhere, right? So we got a single database. All we really change is configuration issues. And so we can report business and clinical measures every day across that whole continuum of hospitals and episodes of care and all of that, and drill into each of those with a system that we built. We call it Beacon, but it's essentially a BI system that has worked well to mine the Cerner data to give us visibility into, what is happening everywhere.
Well, it sounds like you aced it for both the patients and the clinicians. So that's awesome.
Yeah, I got to give it to the team. They're just incredible, and we've been working together for 7-8 years now on it, and it's really come together.
Yeah, well, it's great to see the data being used for something other than chasing government money. So I love it. Thanks for sharing.
Unfortunately, we did not get any government money. We paid for this on our own, and we felt it was the thing we needed to do to support the healthcare in the community, and in fact has worked out.
Well, it's interesting also that you have you kind of talk about the growth of Encompass Health. It sounds like you have an aggressive growth strategy there. How does your EHR strategy align with that? Or, are you to the point where when you acquire, you may just leave the EHR? Because I imagine many that you're acquiring now have an EHR, or are you still planning to centralize it as part of similar strategy you just described?
Yeah, so the 6 to 10 is hospitals that we build. And if we do joint ventures, then, you're part of our joint venture arrangement is that we're going to get our system so that we can manage every hospital in a standardized format. It works great because almost 3 years ago, I got assigned the responsibility for design and construction. And I go, oh, wow, okay, how does that go together? Well, it's really process too. So what did we do there? We went and we built a great team. We've standardized on the hospital rooms, et cetera. And so we replicate that. And this year we're going to open 9 hospitals. We're going to open 9 next year. And in fact, we've gotten it so standardized that we're using some prefab construction that we just deliver on 18-wheelers. And there comes a room, a hallway in another room, and just chunk them, set them right out. In fact, they work really good for bed addition. So in a lot of our communities, we're at capacity, and that gives us a very quick turnaround on being able to add capacity. The EMR is standardized as well, and we put it in from day one. So you don't know any different. And by day 2, we're able to reflect on the management and clinical things that are going on in that hospital with everybody else. So we can, as a hospital comes on board, we can compare it to somebody in a similar position and, then affect change where we need to affect change.
Yeah, that's interesting from a baselining perspective. You have all that data because it's so standard across your organizations. That makes a lot of sense.
Yeah, it's beautiful.
Well, over the years, I've seen you at a lot of conferences. We've talked about a lot of technologies. I remember you telling me about voice and some efforts in voice that were successful with your organization. But what technologies or maybe projects do you see are kind of crucial to your current strategy?
Yeah, we're We need to modernize a couple of things. Our patient revenue cycle system, we need to modernize it. It is actually on 151 databases,
Hmm.
and it's built specifically for us, but it is time to modernize that. So we are on a pilot project with Cerner to put in their revenue cycle system. We'll put it in at one hospital as a pilot, and then we have a centralized business office as well. So we'll carve out a little piece of that business office to, evaluate that. And then if that is successful, which we think it will be, it's going to provide us some good opportunities in the integration between Millennium. In this case, the pilot will be on Sorian for registration and other things. So the hospital folks, I think, are going to get a really good benefit from having to log into two different systems and admit patients. So we're pretty excited about that. I think the ability of some of the workflowing that we've seen in the system will help our business office as well. So we're looking forward to that. We're also begrudgingly going more to the cloud. We're working on Office 365. And I say begrudgingly because it's challenging from an operating expense perspective. And that's really the only reason that we've been slow to go in there, because we like the capabilities that present, but it's costly, as any of the CIOs out there will know. We've got about a third of our hospitals on Office 365, so we'll be doing that the rest of the year. We're also looking at our ERP and our supply chain systems in the future. So we're in a little bit of a rebuild mode to set us up for the next few years. And, on the EMR side, we're going to continue to work with Cerner in the Post-Acute Innovation Center. In fact, we did two more algorithms. We did a readmission algorithm that used our home health data, an organization we used to own, as well as our data, and built a readmission algorithm, and one that is super great for our patients. And we just really are loving it. It's only been out for about 6 or 8 months, and it's a fall prediction algorithm. So we used to use a fall prediction that was probably acute care based. Well, our patients are different, right? We're getting them up 3 hours a day, and they have a propensity to fall because they're moving around. And so we thought, again, we've got all this data. So we mined that data, and we put together a fall prediction algorithm with Cerner's help, with the data scientists, our clinical teams, and we've seen a great reduction there in the fall prevention. Now, the other thing that we do that is super important to all that kind of activity is to build a program. You can't just throw that IT out there and expect, the first thing that, well, I need to see the data and blah, blah, blah. And it's really challenging with their academic medical centers that they really want to get to the bottom of it. So that was part of our impetus for building what we call the clinical beacon, so that we can show, here's the things that are driving this algorithm in the workflow. So we took our ClickView environment, hooked it up into Cerner on Smart on Fire. And, most of the EMRs are challenged today to show trending and other things that are pertinent for that particular organization. That gave us the opportunity, to really give the clinicians, here's some trending. When you walk in the morning, here's all your patients in your hospital, and these top 5 are the ones that are sicker than the others. Concentrate on them first, and then you're in a better position for everybody's quality of care. So that relationship with our innovation center has really paid dividends.
Wow, that's some great work. So as I think about the hottest topic right now in the industry, it feels like workforce is the biggest challenge that many face in retaining workforce, or whether it's your own IT staff or clinical staff. So on both sides of it, it's a challenge. What efforts are you making to really retain staff?
Yeah, so you made it. There's two things, right? There's the IT staff, and one of our biggest challenges is the clinical staff. On the IT side, we start with a mission, and the mission is, if you take care of the caregivers, they'll take care of the patient, and everything else will take care of itself. So when you get the mission, you can build culture, and then that culture will do what? It'll breed self accountability. So this team that I've been working with, they're incredible. This year we've got about 5% turnover in IT. Typically we average about 4.75%. And our average tenure is 13 years. And that includes, we've got a lot of support, organization people that will kind of come and go. So we've got a long tenure in the back office of IT, which is really enables us, and we know this business. So we're pretty compelling there. In the hospitals, of course, everybody's doing everything they can, to chase this, limited resource. We've been using some cloud technologies that enable a much smoother interface to our potential employees, as well as moving all of their data into the system as soon as we get it, doing role-based stuff in our EMR. So if somebody shows up to work, they can start working that day with their training. So everybody's running at that one pretty hard, and we're doing the same. I think we're finally starting to see a little bit of a turn down in it. So we're happy about that.
Yeah, it's going to be a battle for I think years to come for many organizations. So we're in for the long haul. So we always like to wrap up our CIO podcast with a little bit of career advice or career perspectives. So what would you say is maybe the best piece of advice you've received in your career?
So I'll say it and then I'll figure it out later. But no,
okay.
no. So learn to ask for help. That's kind of hard to do. So as I came up through my career, as many of you guys out there did and gals out there, you got a lot of advice, and it was good advice. And some of the best advice was, what do I do in this particular situation? That's good because you get it. And if it's good advice, then that really moves the organization forward. And especially as you're working up the ranks. Well, as you get up to the pinnacle of an IT person's existence, you're at the CIO level, you're not getting much advice, right? Because you're the guy or gal that's supposed to know everything. And so what do? You got to learn how to, and it's counter to what you've done most of your career. You've gotten good advice, but it's counter to asking. You got to ask. So that was the best advice I've got. I struggled with it for a long time. I'm a lot more comfortable with it now, utilizing my Chime network and other networks, using the vendors for things because they see a lot of things that you don't see. You see your stuff, they see all kinds of other stuff. And so me learning how to ask for help, ask for advice has been the most compelling thing that I've gotten advice about. And it took me a long time to internalize that. So I wholeheartedly recommend it. And I'm a pretty shy guy, so that was challenging.
I don't know how shy you are, but it is interesting though, right? That whole juxtaposition between I should know it, I'm the boss, I should know this information. And yet, how do I show, leadership and, stability and confidence, but then also to be humble enough to say, I don't know everything and that I need help. I think you gave some great suggestions there about having a network outside of your organization as well, to be able to connect and be able to be vulnerable and ask the hard questions that you don't know the answer to.
Yeah. And we use it a little bit more discreetly too. And I call it, well, we got to get everybody in the boat. So we come into a room together and, okay, here's what we're going to do. What are your thoughts? What are your thoughts? Oh yeah, I didn't think about that. And so it really circles up some of the threads that if somebody were to pull on them could, get the project to come apart. So we say, okay, everybody in the boat, and we kind of look around. Yep, we're all in the boat. So we're in it together, just like we talked about out in Phoenix is we're all in this together. It really helps bind the team, and, we build mutual respect that way. And then ultimately the accountability goes along with that.
Yeah. I'm impressed on how you bring people together in the same boat. I have a feeling some people listening or watching are going to want to check out jobs in Birmingham, Alabama. So
we hire remote, no problem for IT. We're
I
in search of a couple of security people.
hear the coast is great in Bama, though.
Yeah.
Excellent. Well, Rusty, thank you so much for taking the time and sharing your insights and perspectives. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for the CIO podcast by Healthcare IT Today on your favorite podcasting channel. Thanks so much, Rusty.
Thank you all.